Assalamu alaikum, dear audience. I am Professor Shamsuzzaman, Professor of Pathology. I welcome all in today's 14th lecture on Hematology. Today's topic is Polycythemia vera. Before going to discuss about Polycythemia vera, we have to recapitulate myeloproliferative disorder. Polycythemia vera is one of the myeloproliferative disorders. Disorders results from uncontrolled proliferation of progenitor cell is called myeloproliferative disorder. There remains again disorders results from uncontrolled proliferation of progenitor cell is called myeloproliferative disorder. Polycythemia vera is one of the myeloproliferative disorders. Here I have told you progenitor cell. Then suppose this is the bone marrow within the medullary cavity. This is the cortical part of bone. And this one the progenitor cell, the black one are the progenitor cell. The progenitor cell in the bone marrow proliferates and produces specific cells. Progenitor cell proliferates and produces specific cells like RBC, WBC, platelet, and also reticular cell. So, from the progenitor cell we get RBC, WBC, platelet, and reticular cells. If this progenitor cell undergo uncontrolled proliferation in the bone marrow, there will be disorders, and these disorders are called myeloproliferative disorders. Now come to what are the different types of myeloproliferative disorders. Polycythemia vera, essential thrombocythemia, chronic myeloid leukemia, and myelofibrosis. These are the myeloproliferative disorders. Now come to stem cell and progenitor cell. What are the differences between stem cell and progenitor cell. Actually, there is no many differences between these two, but there is difference. Actually, there is no many differences, but there is difference. What is that difference? Stem cell multiplies indefinitely, but progenitor cell cannot multiply indefinitely. This is the difference between stem cell and progenitor cell. But both cells are associated with production of specific cells. Now come to polycythemia. Increased number of RBC, WBC and platelet in blood is called polycythemia. Dear audience, in polycythemia there is poly, it means many, cyte means cell. So increased number of RBC, WBC and platelet in blood is called polycythemia. Respected audience, we know per cubic millimeter of blood RBC average 4.5 millions or 5 millions. WBC 4,000 to 11,000 and platelet average 3.5 to 4.5 lakh. So if we consider 1 cubic millimeter of blood, in 1 cubic millimeter of blood, RBC is about 4.5 millions or 5 millions, WBC 4,000 to 11,000, platelet 3.5 to 4.5 lakh. If in this 1 cubic millimeter of blood, RBC is more than 4.5 millions, WBC more than 11,000 and platelet more than 4.5 lakh. By definition, it is called polycythemia. So in polycythemia, RBC, WBC, platelet, all the cells are increased. Types or classification of polycythemia. How can we classify polycythemia? One is true polycythemia, Another is relative polycythemia. First come to true polycythemia. In true polycythemia, what happens in the bone marrow? There is uncontrolled proliferation of progenitor cell, or there is excessive proliferation of the progenitor cell. Or excessive proliferation of progenitor cell. True polycythemia may be primary true polycythemia. In this type of polycythemia, there is uncontrolled proliferation of progenitor cell, but the cause of uncontrolled proliferation is not known. Uncontrolled proliferation of progenitor cell, but the cause is not known. This is primary true polycythemia. Secondary true polycythemia. In this type of polycythemia, there is excessive proliferation of progenitor cell. And the cause of excessive proliferation of progenitor cell is known. Now come to what are the different causes associated with secondary true polycythemia. Number one, tissue hypoxia. Tissue hypoxia is associated with secondary true polycythemia. What are the causes of tissue hypoxia? Cardiac causes like cyanotic group of congenital heart disease. Lung causes like chronic obstructive pulmonary diseases. Dear audience, you know chronic bronchitis, emphysema, bronchiectasis, bronchial asthma. These are the COPD, chronic obstructive pulmonary diseases. These are associated with tissue hypoxia. Another is high altitude. These are the situations associated with tissue hypoxia. If there is tissue hypoxia, why there is excessive proliferation of progenitor cell, Dear audience, you know tissue hypoxia, release of erythropoietin, from kidney, and stimulation in bone marrow. As stimulation in bone marrow, there is excessive production of RBC, WBC, and platelet, and this is nothing but polycythemia. Now come to relative polycythemia. Dear audience, again we recall, in true polycythemia, there is either uncontrolled proliferation of progenitor cell or excessive proliferation of progenitor cell in bone marrow. But in relative polycythemia, there is no uncontrolled proliferation or excessive proliferation of progenitor cell, but there is increased number of RBC, WBC, and platelet in blood. Why? It is due to hemoconcentration. Due to hemoconcentration. What are the causes of relative polycythemia? Excessive vomiting, diarrhea, excessive sweating. These are associated with hemoconcentration. Dear audience, we can compare relative polycythemia with an example. Suppose this is a bucket and this bucket has 5 liter water. And within 5 liter water, there is 20 small fishes. 20 small fishes. So if there is 20 small fishes in 5 liter water, there will be 4 fishes per liter water. If 1 liter water is removed from, again, if we remove 1 liter water, then 4 liters water contains 20 fishes. In this situation, 5 fishes per liter water. As due to removal of 1 liter of water, there is increased number of fishes per liter of water. This is nothing but example of hemoconcentration. Our topic is polycythemia vera, a type of myeloproliferative disorder. Now come to polycythemia vera. Dear audience, it is a type of myeloproliferative disorder, and it is primary true polycythemia. The cause is not known, and there is uncontrolled proliferation of progenitor cells. If anybody suffers from polycythemia vera, in blood will get increased number of RBC, WBC and platelet. And what may be the presentations of the patient suffering from polycythemia vera? Clinical presentations. Cerebral symptoms like headache, dizziness. Why headache and dizziness as cerebral symptoms in polycythemia vera? Dear audience, you know, as there is increased number of RBC, WBC and platelet in blood, the viscosity of blood is increased. As there is raised viscosity of blood, there is sluggish flow of blood through the cerebral circulation. As there is sluggish flow of blood in the cerebral circulation, there is headache and dizziness. Red face, red shut eyes, insomnia, weakness, tiredness, generalized pruritus, visual disturbances, like blurring of vision, there will be thrombosis. So these are the clinical presentations. The rodents again, cerebral symptoms like headache, dizziness, red face, red short eyes, insomnia, weakness, tiredness, generalized pruritus, visual disturbances like blurring of vision, thrombosis, etc. Now come to why generalized pruritus in polycythemia vera. Why generalized pruritus in polycythemia vera? Dear audience, you know, in polycythemia vera, there is increased number of RBC, WBC and platelet. As increased number of WBC, it is associated with increased number of eosinophil also. So there is increased number of eosinophil. And you know, eosinophil secretes histamine, and due to histamine there is generalized pruritus. Now come to why blurring of vision or visual disturbances in polycythemia vera. Dear audience, if this is the eyeball, you know there is the retinal artery. As in polycythemia vera, due to increased number of RBC, WBC and platelet, there is increased viscosity of blood, and due to increased viscosity of blood, there is sluggish flow of blood through the retinal artery, and due to sluggish flow of blood through the retinal artery, there is blurring of vision. Now come to thrombosis in Polycythemia vera. Dear audience, you know intravascular solid or semi-solid mass formed by constituent of blood in streaming blood is called thrombus, and the phenomenon is called thrombosis. And you know, for thrombosis, varicose steroid is needed. Varicose steroid is needed, and it includes endothelial injury, alteration in blood flow, and hypercoagulability of blood. In Polycythemia vera, as there is increased viscosity of blood due to increased number of RBC, WBC platelet, there will be alteration in blood flow. Again, due to increased viscosity of blood following increased number of RBC, WBC and platelet, there will be alteration in blood flow. What type of alteration? There will be sluggish flow of blood, and due to sluggish flow of blood, there is chance of development of thrombus in the vessels. Now come to laboratory diagnosis of Polycythemia vera. We have to do blood examination, and bone marrow examination. The audience first come to blood examination. First, hemoglobin. Hemoglobin will be raised. Then come to ESR. ESR is 0 or almost 0. Total RBC count, it is more than 5 lakhs, that is increased. TLC, total leukocyte count, leukocytosis. Platelet count increased. So increased RBC, increased WBC, and increased platelet. It is polycythemia. Now come to bone marrow examination. Dear audience, we have to search for the cellularity, myeloid erythroid, erythropoiesis, granulopoiesis, megakaryocytes. Marrow is hypercellular. Why hypercellular? As there is uncontrolled proliferation of progenitor cell, so there will be increased erythroid series, increased granulopoiesis, also there is increased number of megakaryocytes. So marrow is hypercellular with normal myeloid erythroid ratio. Why the ratio is normal? Because there is hyperactivity of the erythroid series and also hyperactivity of the myeloid series. So normal myeloid erythroid ratio. Erythropoiesis is active and normoblastic. Granulopoiesis is active with all stages of maturation. Granulopoiesis is active with all stages of maturation. Megakaryocytes seen increased in number. So this is the bone marrow findings of Polycythemia vera, and this is all about Polycythemia vera. Respected audience, today I have told you myeloproliferative disorder. Disorders result from uncontrolled proliferation of progenitor cells, and progenitor cell is nothing but stem cell. Both progenitor cell and stem cells are associated with production of specific cells, but there is difference between these two. Progenitor cell cannot multiply indefinitely, but the stem cell can multiply indefinitely. The myeloproliferative disorders are Polycythemia vera, chronic myeloid leukemia, essential thrombocythemia, and myelofibrosis. Polycythemia means increased number of RBC, WBC platelet in blood, and we can classify polycythemia as true polycythemia and relative polycythemia. True polycythemia may be primary true polycythemia, where there is uncontrolled proliferation of progenitor cell but the cause is not known, and secondary true polycythemia. In secondary true polycythemia, there is excess proliferation of the progenitor cells following certain diseases. One is tissue hypoxia. It may be due to heart diseases, lung diseases, high altitude. Another, if increased erythropoietin production, what will happen? This is the kidney, and you know normally from the kidney erythropoietin is secreted, and this erythropoietin acts upon bone marrow, and there is production of RBC, WBC, and platelet. So erythropoietin is nothing but marrow stimulant. If there is excessive production of erythropoietin, there will be increased production of RBC, WBC, and platelet, and it will lead to polycythemia, and this is secondary true polycythemia. Now come to what is the cause of excessive erythropoietin production. The cause of excessive erythropoietin production. RCC, renal cell carcinoma. So if anybody suffers from renal cell carcinoma, there will be excessive erythropoietin secretion and the patient will develop secondary to polycythemia. And we can diagnose polycythemia in laboratory by examining blood and bone marrow. In blood, there will be increased number of RBC, Ws and platelet, increased hemoglobin, almost 0 or 0 ESR, and bone marrow shows active erythropoiesis, active granulopoiesis, and increased number of megakaryocytes. Today up to polycythemia vera briefly. Thanks all.